Hi, everybody, and welcome to the STEMI Live Webinar Series. This is our second week. Last week, we touched on the principles of coronary intervention. My name is Dr. Mohammed Jaylan. I'm standing in for Professor Habib Gamra, who will be joining shortly, but as is the life of an interventional cardiologist, he had to get involved in an interventional case very recently, and he anticipates that it will be done within 20 or 30 minutes of us starting. We have a really exciting lineup. I actually traveled to Jordan to listen to these two speakers only 4 days ago, and they're going to be talking to us about coronary intervention using drug-coated or drug-eluting balloons. Maybe touch on the differences between a drug-coated and a drug-eluting balloon, and tell us about why coronary intervention using drug-coated balloons is so different, yet very similar to coronary intervention using the standard drug-eluting stents that we've been using. And they'll explore a little bit the evidence to support their use and the types of drug-coated balloons that might exist. Our first speaker I've listened to on various occasions, Professor Hussein Hishmat, professor from Cairo, and he also works in the Emirates. He's going to talk to us about the principles of drug-coated balloon angioplasty, present some of the evidence, and give us some historical concepts that will help us understand why drug-coated balloon angioplasty might be the way forward. Over to you to lead us into the next 20 to 30 minutes, Prof. Hishmat.
Thank you so much, Dr. Jaylan. It's always a pleasure to be joining the Pan-African Society webinars. And my name is Hussien Hishmat. I'm a professor of cardiology at Cairo University and an interventional cardiologist currently practicing in the UAE. And this QR code is the link to my phone numbers and emails in case someone needs to contact me for any question. And the title of this webinar is going to be on drug-coated balloons or drug-eluting balloons. And it's not a new technology, but it's like a total shift in the mindset. And so it seems like polarizing the interventional community into two groups. A group that is a faithful believer in the good old technology of drug-eluting stents, you can see the advantages and the long-term record of success, and another group who see stents as meaningless, as redundant, as crazy as trying to shovel a metallic scaffold or an alloy into a living human vessel, and thinking, how does that make sense? And with this presentation, I need you to go out of this war between drug-coated balloons and drug-eluting stents. And I need you to focus and to go back into the basics of coronary angioplasty. How do we do coronary angioplasty? What's an atheroma? How do we treat it with intervention? Because this is the foundation of angioplasty. And if you do that well, then the issue of a drug-eluting balloon or drug-eluting stent would be a secondary or a trivial issue. And for some reason, my practice has evolved to be diverting between drug-eluting balloons and drug-eluting stents. And I see the beauty and the power of each of the two devices, and I see their limitations. So drug-eluting balloons would be my go-to approach in patients with long lesions, patients with diffuse disease where there's no landing zone for the stent, patients with small vessel, small diameters, less than 3 or less than 3.5, where we know that the outcome of stents would not be ideal. Drug-eluting balloons simplify bifurcations, getting us out of the debate between a DK crush and a DK culotte or whatever complex two-stent technique. They have their advantages in calcified lesions, especially the ones that do not yield to lesion modification tools, and it would be, in my opinion, much safer to use a drug-eluting balloon than to place a metallic alloy and risk under-expansion and imminent stent thrombosis. Drug-eluting balloon also seemed to me to be the ideal situation in stent failures, especially those with stent thrombosis, under-expansion, and malapposition, where implanting a second layer of stent would just make the future look more dull. Whereas on the other hand, drug-eluting stents still maintain their position whenever there is recoil after balloon angioplasty or a vessel-threatening dissection, also in aorto-osteal lesions, in vein grafts or arterial grafts, whenever there's a heavy thrombus in patients with STEMI that is not resolving, then placing a drug-eluting balloon in the presence of a non-resolving thrombus would simply waste the drug in the thrombus and not deliver it to the endothelium or the subintimal space. Some cases of in-stent restenosis, particularly due to stent fracture or tough calcified new intima, I still see an advantage for stents in that situation. And it will end up on where you're practicing and what kind of patients do you get. In my practice, I see a lot of young patients, less than 55 years old. And thinking of the lifetime management of coronary artery disease, then drug-eluting balloons take the upper hand. And especially I see patients from South Asia, Southeast Asia, and Far Asia. And what they have in common is diffuse disease, small caliber vessels, and long lesions. That's why probably my practice is a little bit more biased towards drug-eluting balloons rather than drug-eluting stents, where out of every 5 lesions I treat, 4 will end up being treated by a drug-eluting balloon, and only 1 will be treated by a drug-eluting stent. But the common feature between both approaches is I first try to modify the lesion. If I end up with a good result, then a drug-eluting balloon is going to be enough. If I'm not happy about that result, then I think of drug-eluting stents. And because the common denominator is the lesion modification, therefore, this talk is going to be dedicated to that specific topic, lesion modification. So first, let's discuss what is the lesion. The bread and butter is atherosclerosis. Of course, we have some other less common pathologies like spontaneous dissection, like graft degeneration, and that's different from atherosclerosis. We have some hypercoagulable states, but we know that our bread and butter is the atherosclerosis. And atherosclerosis starts in the teen age, and the plaque starts as a fatty streak and then keeps building and piling up until it forms the atheroma. And the word atheroma is interesting. Oma is a Greek word that stands for a swelling or a tumor, rather a swelling. And atherosclerosis ends up growing a swelling inside the blood vessel. And these swellings, depending on the inflammatory status, they would end up in one of two fates. The first fate is the inflamed atheroma, the inflamed swelling. And they used to teach us in my fellowship days that this is like an abscess. It's full of necrotic material and it has a thin layer, and this cap tends to rupture and cause a catastrophe, and it has lots of inflammatory cells. Whereas the other form, where it keeps growing like a benign tumor that is big enough to interrupt the blood flow in the vessel. It has calcified parts, it has tough fibrotic parts, it is less inflamed. Nevertheless, it's obstructing the flow into the lumen. And because most of the attendees are interventionists, so thinking and trying to understand the mindset of a surgeon who's dealing with a swelling. How do they deal with abscesses? They have to drain the abscess. How do they deal with a tumor that's obstructing a hollow organ? Then they try to excise it. And this is exactly what we are trying to do with coronary angioplasty. Intuitively and romantically, or in a naive way, we tend to think that the balloon stretches the vessel wall, whereas in fact, stretching the vessel wall is the least important among the actions. Balloons act on crushing or compressing the atheroma. and they work also on tearing of the atheroma, denuding the surface of the atheroma. If you remember that the pressure in the tire of your car is around 3 to 4 atmospheres, whereas we're very happy to go 12, 14, or even 20 atmospheres with a balloon. So guess how much pressure do we need to put on the atheroma, which is mostly hard material, in order to break the atheroma. And so the main mechanism of action of angioplasty is by fracturing the atheroma, draining its contents and denuding the intima, and to a lesser extent stretching the vessel wall. And these are not my words, these are the words of people who invented coronary angioplasty. So I would urge every one of you to go to this seminal publication published more than 20 years ago by Bernie Meyer, who was one of the early apprentices of Andreas Grunzig. And what he describes by coronary angioplasty is that the balloon angioplasty impacts the vulnerable zones and induces an immediate rupture of the fibrous cap. So he acknowledges that the mechanism of action of angioplasty is rupture of the atheromatous cap. And we do that in a controlled environment inside the cath lab, where the patient is anticoagulated with heparin and there's dual antiplatelets, making the risk of abrupt vessel occlusion extremely low. So what do we know? What do we learn from here? That angioplasty works by rupturing the atheroma. And the handy way to do that is using a balloon. And these balloons, they all come folded. And once we bump up the inflator, they tend to unfold. So this process of unfolding creates some slashing effect or shear stress on the atheroma. So as the balloon unfolds, it will inevitably create dissections. And as we denude the intima and rupture the plaque, we're creating a false track inside the vessel wall. So dissection and plaque rupture is the main mechanism of coronary angioplasty. After we do that, we break the plaque and we gain lumen. We can end up with a balloon or a stent in order to deliver the drug. But what happens after ballooning or stenting? Remember that we're inducing a lot of pressure, we're putting a lot of pressure on the atheroma, and we're injuring the intima. So we're inducing vessel injury due to stretch or due to slashing the intima and breaking the atheroma. This induces an acute inflammatory reaction, and the body tries to heal. And the main way of healing in the vascular system is by formation of new intima. This new intima comes from the surrounding endothelial cells and also comes from the vascular smooth muscle cells. And if we examine the intima grossly, I mean the new intima, and look at it in a gross way, the surgeons will tell you that when they open an endarterectomy, when they open a carotid after an endarterectomy for restenosis, this new intima looks like shiny, glistening, and slippery. And remember, whenever you're using a regular semi-compliant balloon or non-compliant balloon to treat an instant restenosis, the balloon keeps on slipping. Unlike atherosclerosis, which is hard and rugged material, new intimal hyperplasia is slippery. And why does that make sense? And why is it important? Because this new slippery new intima is mostly resistant to thrombosis. And that will help us understand why the incidence of myocardial infarction is extremely low after a balloon angioplasty with a drug-eluting balloon or a regular balloon. Myocardial infarction is more or less the same. But there might be a tendency for more myocardial infarction if we insert in the middle of this new intima a stent, because the stent is a metallic structure and it will always incite thrombosis. But this slippery new intima will help us understand why drug-eluting balloons are very good in preventing future myocardial infarction, even the platforms that didn't do well. But this new intima comes with downsides. If they keep growing inside the vessel. So if left unchecked, they will result in occlusion of the vessel again and the need for a repeat revascularization. So the aim here is to modify the lesion and then deliver a drug to suppress the future formation of new intima. We can do that by a drug-eluting balloon or a drug-eluting stent. So we describe the lesion. How do we modify that lesion? Balloons, of course. We have non-compliant balloons, high-pressure balloons, cutting, scoring, IVL balloons. We have laser and different ways of atherectomy for calcified lesions. And we do that with a considerable and meaningful use of force, the rational use of force. If the lesion is mostly soft and mainly thrombus, then thrombus aspiration is probably enough. For regular and soft lesions, semi-compliant balloons might work, but I personally stopped using them except in a very few cases when I don't have the size of the NC balloon, because NC balloon has a big advantage over semi-compliant balloon that I will describe shortly. When there is fibrosis or some calcification, I have a very low threshold to use scoring, cutting, and high-pressure balloons. I always stock enough of them in my cath lab. For severe calcification, of course, we need to break the calcium with orbital rotational atherectomy or laser. And the reason why I almost abandoned using semi-compliant balloons is because of their dog boning effect. Because once we put more pressure, this pressure is not directly transmitted to the atheroma as we wish in order to break it, but it results in enlargement of the balloon. And so the balloon tends to enlarge in the softer areas of the vessel. Therefore, they tend to create disproportionate force. And here, if the vessel is going to be injured or ruptured or perforated, it's going to be in the edges of the hard atheroma and puts pressure on the soft parts of the vessel. Whereas the non-compliant balloon, when you build up the pressure, it doesn't grow disproportionately. It will grow in a uniform way, and all the pressure will be transmitted into the atheroma, helping to break the atheroma and rupture the atheroma. So my main focus is non-compliant balloons. And we learned the caveats along the way that improved the outcomes for drug-eluting balloons. Sizing is extremely important. I may show you cases where colleagues try to treat a 4 millimeter vessel with a 2.5 millimeter balloon. It's never going to be enough. The other point is a gradual inflation and a gradual deflation. And gradual deflation tends to avoid the vacuum effect and tends to maintain the dissected intima adherent to the wall. And probably one of the most important caveats is a prolonged contact. You will see it in your practice. If you inflate the balloon for 15 seconds, 30 seconds, you get some effect, but not the best effect. But if you have the luxury and the tolerance of the patient to inflate it for 2 minutes or 3 minutes, then you will see a marvelous effect. So gradual inflation, prolonged contact, and gradual deflation. Scoring and cutting balloons are game changers because they do not slip like the regular standard balloons. And the dissections that they create are not haphazard, are not chaotic. They tend to create controlled incisions into the atheroma that helps to modify the atheroma rather than creating chaotic dissections. And they tend to hold on the atheroma because of the cutting blades or the scoring nitinol elements that we have on the surface of the balloon. So they tend to modify the lesion better and tend to give us a wider minimal lumen area. And they will have also an advantage when we're dealing with dissections. I get a frequent question about calcified lesions. How does this concept apply to calcified lesions? And let's imagine that we have the worst type of calcium, which is a 360-degree ring of superficial calcium. What we try to do first is to break the calcium using an atherectomy or an IVL. By creating breaks in the calcium and changing the compliance of the vessel, a balloon then can push these calcified racks apart and then give us a wider lumen. So the concept of lesion modification also works for calcified lesions. And so you do your best in modifying the lesion. If the final result is okay, then a drug-eluting balloon would be, in my opinion, the ideal choice. If you are in doubt, then I would think high of a drug-eluting stent. But what do we mean by success in lesion modification? We have three criteria. Number one, having TIMI-3 flow. Number two, having a residual narrowing of 30 to 40%, not more than that. And number three, by having a non-vessel threatening dissection with the 30-30 criteria that I will describe shortly. So TIMI-3 flow is easy to understand, but residual narrowing of 30 to 40%, why should we accept that? We don't accept that with stents, so why should we accept that with drug-eluting balloons? Because of the late positive remodeling. If we compare patients, and we see that in angiographic follow-up, the patient immediately post-treatment, of course, the lumen has improved a lot. If we do a follow-up angiogram after 6 months or 1 year, we see a tendency of the vessel to grow. And this is mainly by the dissections that we induce. We don't see the similar phenomenon with drug-eluting stents. A stent is a metallic implant that tends to cage the vessel and in a philosophical way tends to stop the vessel from growing. Whereas with drug-eluting balloons, we continue to have late lumen enlargement. So look at the residual narrowing and the TIMI flow, TIMI-3 flow, it's fine. The residual stenosis, 30 to 40%, less than that is a DCB, more than that is a drug-eluting stent. And I know that there's inter-observer variability in angiography. One operator who's a believer in drug-eluting balloons would say, oh yeah, that's fine. This is 30%, let's put the balloon. Another operator who's trained mostly on drug-eluting stents, he said, no, this is a significant residual narrowing, let's stent. So in order to get that in an objective way, we can do either physiology or imaging, but the details we can give it in a separate talk on how to use it for drug-eluting balloons and stents. TIMI-3 flow, residual stenosis, 30% or less, a non-vessel threatening dissection. And I know that the mantra of coronary intervention now, once you see a dissection, then you have to stent. But I assure you that that was not the situation 35 years ago. Stents in my country became available in 1996. So this study done in 1992, before stents were available, they looked at the morphological effects of coronary balloon angioplasty assessed by IVUS. So these were the early days of IVUS and probably the glory days of regular plain old balloon angioplasties. So they looked at 66 lesions, they did balloon angioplasty and they did an intravascular ultrasound, and they looked at dissection by IVUS and by imaging, and they tried to correlate the extent of the dissection with the chances of restenosis. So what they found is dissection is almost universal. You can see it by IVUS and not see it by angiography and the other way around. And then they graded the section into several grades. Type E, where there is almost no dissection, where the atheroma just got stretched and there was no tear in the plaque or a dissection. That's type E. The other types, we have type A, where there's just a linear tear that is not extending all the way to the full thickness of the atheroma. Type B, where the tear extends into the depth of the plaque, but there's no evidence, it's not extending behind the plaques, and the two ends of the plaque are not torn. Type C, there is separation of the torn ends. Now you have a flap that is playing around in the vessel up to 180 degrees, and if it extends more than 180 degrees, then this is type D dissection. So before I show you the results, in your opinion, which type of dissection would be associated with more restenosis after balloon angioplasty? Intuitively, you tend to think that less dissection means less restenosis, but in fact, it's the other way around. It's the opposite. Those lesions that were not dissected, were just stretched, they had between 20 to 50% restenosis. Whereas those lesions where we extensively dissected, look at type D, where we smashed the intima completely all around the vessel, there was zero restenosis with plain old balloon angioplasty. So the more we dissect, the less the restenosis in the long term. And this has been replicated again in 2020 by a group of Japanese interventions who are also very faithful about drug-eluting balloons. They graded the dissection in a more geometrical way, extending along the length of the treated lesion. And they came up with a dissection index. And they found that on follow-up, patients with a higher dissection index tended to have larger mean vessel volume and larger mean lumen volume. They tended to grow the vessel more. These dissections, when they heal, they create an extra lumen in the vessel. So dissection should not be viewed as your enemy. A controlled dissection should be viewed as your friend. So how to avoid the vessel-threatening dissection where you're scared that the vessel is gonna shut down within minutes or hours, and they would call you in the middle of the night because the patient is having an acute MI after the balloon angioplasty that you did. And here, the nice work by Simon Eccleshaw and his colleagues, they came up with the acronym ARM strategy: avoid, recognize, and manage the dissection. First, how to avoid? You need to be cautious, probably undersize your balloon a little bit in elderly patients, female ACS, lesions that are tortuous, long diffuse disease, higher inflation pressures at the bifurcation or a curve. These are the situations where you expect your dissection to be a little bit wild. You need to recognize the vessel-threatening dissection when the TIMI flow is reduced, when there is ongoing chest pain or ECG changes or hemodynamic changes, or when the contrast keeps hanging in the vessel. The contrast keeps hanging in the vessel means that the false track that we created by slashing the atheroma, blood is flowing inside, but it's not flowing outside. It means that it can continuously grow over the coming minutes or hours, and then it will end in total collapse of the vessel lumen. And I know there is the classic National Heart Lung Blood Institute grading of the section from A to F, but in my opinion, this is really difficult to assess in the cath lab and grade from 1 to 6 and take decision based on this complex grading. So based on the work of Antonio Colombo and his colleagues, we wrote an editorial, me and Dr. Shehab among the speakers today, about how to handle a dissection, and we came up with the rule of 3-30-30. If TIMI flow is less than 3, then don't accept that. Don't just put the balloon, aiming that the balloon would treat everything. No. TIMI less than 3 flow means there's something wrong. Either the dissection is impairing the flow or there's still a large thrombus that is forming, so you need to do something about it. If the residual narrowing is more than 30% in the presence of a dissection, then you should not accept that result. You should either stent or try to do something to improve the residual stenosis. Or contrast staining that lasts more than 30 seconds. As I told you, it means that the vessel is filling with blood. The false lumen is being filled with blood and is not draining, so it will continuously grow until it blocks the lumen. Keep in mind that if the dissections are not flow limiting, less than 30% residual narrowing, no contrast retention, then you'll be very happy to leave them and they will grow the vessel in the long term. Make sure the ACT is therapeutic and make sure your antiplatelets are working. We have some balloon techniques, prolonged balloon inflation. I told you the longer you inflate, the less will be the severity of the dissection. Cutting and scoring balloons are useful. I'll show you how. And if all these maneuvers don't work, then of course, there's no shame in stenting. Heparin is extremely important, especially when we have a hematoma in the vessel wall, because we need this hematoma to be fluid, not solid. And I've seen many cath labs where, where they don't give enough attention to anticoagulation. They just give an empirical dose of heparin and they do not check the ACT frequently, so they end up in trouble. So we give the bolus 70 to 100 units per kilogram, and we check after 5 to 10 minutes, and we recheck every 30 minutes. If the target is not achieved, then we give an additional weight-based bolus 2,000 to 5,000 and recheck 5 to 10 minutes later on. For stents, so we've discussed atherosclerotic lesions. Lesion modification in stent restenosis is one of the daunting tasks because you have a mix of underexpansion, malapposition, could be geographic miss, stent deformation, stent fracture, new intima, new atherosclerosis, a tendency to thrombosis. So lesion modification here is more difficult because I'm trying to think how can we expand a stent that was wrongly placed 2.75 and you needed to adapt to a vessel that is 4.5. How will you treat stent restenosis in that way unless you unravel the stent and put on a new stent? That's why in in-stent restenosis or in-stent syndromes, I rely on imaging to understand the mechanism. Very low threshold to use cutting, scoring, IVLs, and I tend to oversize the balloons. And also, if I'm not happy, then my threshold to repeat stenting is very low. So you modify the lesion. This is the basic concept that I needed to adopt in interventional cardiology because it will improve not only your drug-eluting balloons, but your drug-eluting stents. If you think that dilating a 4 millimeter vessel with a 2 millimeter balloon just to get the stent in and then rely on the stent expansion to break the atheroma, then you will end up with under expansion and you will end up with stent failure. So modifying the lesion improves your total outcomes with drug-eluting balloons, with drug-eluting stents. If you're happy with lesion modification, then a drug-eluting balloon would be the device to go. If you are in doubt or you're not happy with the result, then a drug-eluting stent would be among the best options. So the aim of angioplasty is to disrupt the atheroma. The aim of the drug-eluting balloon or stent is to control the neointimal hyperplasia. You modify the lesion and assess the residual narrowing. For dissection, remember, anticipate, recognize, avoid, recognize, and manage. Remember the rule of 3-30-30 with dissections. And once you adopt this strategy, your results will become better with balloons on stents. It works with large vessels and with small vessels. Thank you so much, and you can feel free to contact me at any time, and I'll be ready for questions at your convenience. Thank you so much.
Thank you so much, Hishmat. Very elegantly presented, not just teaching us how to do drug-coated balloon angioplasty, but reminding us about what we're trying to achieve even when we have to do drug-eluting stent intervention, and really explaining the rationale behind the very disruptive approach to lesion preparation that we are hearing about and learning about and understanding more and more of. We will be moving on to Professor Abdullah Shehab, and I'm hoping that Professor Abdullah Shehab's able to share his screen. I don't know if Abdullah, you're able to share your screen.
Yeah, I'll do it now.
Excellent.
You see it? You able to see it?
Yes, we can see it. It's very, very, very clear. Thanks so much. I'll just make a brief introduction. Professor Abdullah Shehab is known to many of us because he's a very active participant in the PASCI PAFSIC WhatsApp group. He's also, if you like, somebody whose practice has changed significantly following the development of drug-coated balloons. He's a professor of cardiovascular medicine at UAE University, the vice president of the Gulf Intervention Society and the Emirates Cardiac Society. And he's also involved in the hypertension working group of the ECS. He's also involved in writing a position paper on drug-coated balloon angioplasty by the Gulf Interventional Society, like Hishmat. And one thing I'd like to let people know that we've learned about the Gulf Interventional Group is that they get their hands on the new technology sooner than most people in Europe and North America. And they get to practice on the very expensive stuff very early. So they're usually, right at the cutting edge, maybe ahead of the cutting edge for intervention. Without further ado, Professor Shehab is going to be showing us some cases illustrating the principles that were discussed in the earlier presentation. Over to you, Abdullah.
So thank you very much for having me. And really, what I wanted to have today is just an introduction and what we do normally in our activities. And Hussein Hishmat, actually, I said the success of this approach is really modification. If you follow what Hussein Hishmat said, the goal is done. I mean, my talk will be very, very simple. So basically, what we need after that is not just operator, it's need a whole system, because the success, the survival of your approach will come with having a system there and share the standard and responsibility. So we all know from if people talk about evidence, I think evidence for me is interpretation. Doesn't matter what there. If you want to read the evidence is already established for instant stenosis for small vessels, and we have for de novo. But still, people asking for evidence. Of course, this human being never be satisfied. Things which is growing as emerging, of course, for complex multi vessels, and of course the area which is still, I think converging. I think it's for STEMIs and left main. These are coming, but there are some centers who their evidence is their practice. This for me, my evidence is I see small one, then I practice it, then I gain my evidence. That's what I do. So Hussein Hishmat showed you his approach. This is my approach for lesion nowadays. I think life is going back to future, they say it. So thesis, antithesis, synthesis, and we've gone back to we try to keep the biology. There is injury, we modify the injury, and we let the injury heal in the right way. Without having a foreign body. That's what the aim most of the time. And after PCI, we have a problem nowadays with two things happening with the current practice. We have stenosis and we have thrombosis, and that's because of having a foreign body there with the antiprotective medication. So DCB is a biological therapy without permanent implant, allow shortening antiplatelet exposure. A stent is a mechanical scaffold requiring prolonged, and for reason is already mentioned. This is what I practice after I do the DCB. Most of my cases 1 to 4 DAPT and then SAPT. High bleeding 1 to 4 weeks, depends on individual case. I mean, I cannot say for everyone. And those very high bleeding 1 week DAPT and then SAPT. I mean, there's no evidence. Evidence is growing, but I said at least this is from my practice. Let me share with you a case which, again, to practice what Dr. Hussein Hishmat said. This is, again, it's long time ago. I think this is when I started to use the DCB. I had this young patient who are non-adherent, ideal patient for this kind of approach. Hypertensive, poor adherence to the medication. You can see the LAD is almost, and you can see is CTO, or you don't know what to, but basically coming to us, we're worsening angina. How long? He says 2 weeks, 2 months, you don't know. He says on and off for a long time. And you see also the right coronary also disease somewhere here at the mid and there. So this patient needs, to consider how am I going to approach this patient, not just the lesion, but as a human being. So you need to address everything. It's not, the cost, the medication, this adherence and everything. So I thought, for any lesion nowadays, I have no idea what's going to happen until I finish my modification, which said by Dr. Professor Hussein Hishmat. Modify the lesion, take your time, balloon inflation. You can see at that time I remember semi-compliant. I wasn't compliant, but this is what I learned later on. This patient I used semi-compliant, prolonged. Once I got a proper with some dissection. You can see here some dissection there. It's not a stent-like artery, but what I wanted is a TIMI 3, agree? TIMI 3, dissection less than B. There's no staining, okay? So now I ask myself, this is the lesion which I need to get acutely safe. What I happen in future later on, hopefully with this, if I leave the patient like this, that will grow or at least remain the same based on many things, based on the patients taking the medication, secondary prevention, and on base also of my modification. If it's not ideal, maybe not ideal, but it's not bad for me. That was like 7, 8 years ago. Oh, so this patient, that was the results he came with. You can see on left side, and that was the end up like that. He went home. So he went home and never came back to us. This is what happened to these patients who are not adherent. They're not adherent even to the follow-up. They will not come back to you. So happened that they called me. They say this patient now coming back with pulmonary edema, shortness of breath, some chest pain. So we all worried, we said, okay, must be the occlusion of the artery. At that time was new learning for us. So this was his artery actually 4 months after that. Imagine this patient was not taking medication at all. Remember, just 1 week. It was 1 week. What happened to him? He had basically heart failure. Why heart failure? I don't know, many reasons. So, but that we stabilized him. That was ECG. That was his artery. So that was a kind of, for us, as a waking up, for us, it's not. Imagine if the patient had a stent at that stage, and not taking the medication, even worse. So this patient went home with optimizing his medication. Hopefully he'll take his medication. I don't know. It's been at least coming back to us on one single antiplatelets as well, and one of the SGLT2 just to help him with his heart failure. So that was an eye-opening for us. An older man, this man is very interesting. He went to another colleague in another hospital, and they did angiography for him and say, look, you are hopeless case. Basically, you need a bypass. How are you surviving? So he just ran away from him, and he came to us, heard that our approach is different. So he came to us. I said to him, look, if I look at this angio, I said, look, you need a bypass as well. He said, no, bypass, I will not go for it. I said, okay, let me then work up with you the journey. So let us see what we can do for you. This patient had, RCA occluded, LAD occluded, LCX occluded, living in few branches here and there. So my approach is to, open some of the arteries I can. Then I maybe convince him again to go for bypass. Still, the patient, after I opened this LAD, he went and came back to me, say, look, I'm fine, but I think I still have 2 lesions remain. I said to him, I know I've done that for you, but let's look again and see what we can find. So after I did his LAD and I did his, I think I did also his LCX and another. The whole idea was when I approach these cases is to modify, you make the safety, you apply your DCB. That was the case for this patient. So basically, you can see that. Sorry, just going back to that. So that patient, at least I left side I did what I can. There are some dissection in OM, there are some dissection in LAD, but this patient now, 4 years, he came to me and he's a 64 years old. He remained with RC occluded, but this is his lesion which I left with, and he's fine. I've not angioed him after doing his LAD and LCX. They were like 6 months apart. He's living on one, I think, single antiplatelets and lipid medication which he doesn't take, like already 3 times a week, and nothing else. So I'm happy. He's happy. What I want more than that, he says he does exercise and he's fine. So that was an option. This younger man, again with hypertension, stress positive, and you can see multivessel disease, RCA, LAD, OM, multiple lesions. Again, this, one can say, look, and instead of saying, look, I will do for you DCB here, or I'll do a stent here. No, don't say that. Do the same approach as Dr. Hishmat said. Look, I modify the lesion. If, not get the result, which is, you already heard, I will stent. There's no shy about that. But if I get a good results, TIMI 3, residual less than 30, no staining, no ECG changes, patient is fine, which we did for him. Okay, so this patient, basically, that's what we did. We did this staging. So we went with the first of all with his OM, which was easier one to do, and that was the result at the end. So we went to scoring balloon 2.5, 12, and then we went with the after that, we did a good DCB and different views, different projections, so we don't miss any bad dissection, because sometimes you get a very bad dissection in other views. That was the end results you can see on your right side. That was nice OM. Then this patient, I think we continued his LAD and same session. Again, you can see some dissection type A maybe with some residual stenosis. But again, look at the TIMI3, no staining, and residual less than 30. I think maybe again people different of that. Anyway, that was his results, and he went home. After I think a year, came back to us with vague symptoms. So we thought, okay, let's look at what we find. We found his OM or OM is fine. LAD, that's not that brisk flow, but I don't know the reason for that. Maybe we some kind of the way with the catheter was sitting, but nothing there. RCA, of course, which we left last time, getting worse slightly because he was not adherent to the medication, as he says to us. So I thought, okay, let's do the RCA that time. This is 1 year later. And we did the same thing, same principle, scoring balloon, getting the proper dissection. And then after we satisfied, we get a TIMI3 and residual stenosis less than 30, no staining, no ECG changes, no chest pain. There's no reason for, I said, to put a metal to deliver the drug. I said, let me deliver the drug, which you needed only for future maintaining your artery. So that was the result. That's when he came in. Look, 3 vessels. He ended up with like that, which is like almost back to normal. So there's another case which is of interest as well. This patient went to another institution for chest pain. He had a CT scan. You can see here the CT showed some calcification, but severe stenosis of LAD. Again, this patient's from the way he's living, you don't know the smoker, you don't know the background, but they come to you acutely. For me, that day, troponin actually was slightly raised. So I just looked at his coronary angio as reflect what was on the CT. RCA is normal. Again, this case is different because you can see here the approach was again scoring, but we get some dissection, which you can see here on multiple views. Of course, I didn't get it. Maybe I didn't take a few projection, which you should take different projection. You can see on your right side, you might think there is a dissection, but then after I put a DCB of the similar size to the one I scored, you can see here there is a dissection here. Okay, they think okay maybe there's some hematoma, but different another view looks fine. So that kind of dissection I started to leave it. I mean, it's been like I'm doing the same thing last 3. This is maybe type B, close to C, but I think it's B. But anyways, TIMI3, no staining, you can see, and I was happy about that. Again, this patient now, I just tell you, I think is 6 months after that he's on SAPT and dual lipid medication to optimize his. So he's fine, and we are fine. And let me finish with this 2 cases, which goes with the theme of the of your symposium, which is STEMI. This is a non-STEMI case patient, which is coming with the ostial LAD. Again, maybe erosion happened. Then you can see in different views. I don't know whether I need to touch it or not touch it, but because it was hazy, I thought, okay, at least I will not complicate this case. It looks very complex. If I put a stent from left main to LAD, ostial is very difficult. I know there are people expert doing that with imaging, beautiful result acutely, but problem happens later on. Many reasons. These stenosis happen despite of imaging. So I thought at least I let that area to heal. So ballooning it scored. Once I got the results fine, with no further worse dissection, I put a DCB there, and for again 30 to 60, I think it was intermittent, different views, and you can see the results on your right. It was not bad, I can say. Okay, there are people may disagree. There are some residual, but fine. At least they will let this to heal acutely. You want things to be safe, to be TIMI 3, to be less than 30, to be no staining. ECG is okay. Patient is fine. And this patient now again come back to me after 3 months again on single antiplatelets, and this is ticagrelor here. And let me finish with the last case, which is STEMI. I know it's off-label, but this is what I do for almost all my cases. Not because I decide DCB, because I do the modification. After modification, I find there's no reason for me to put a DCB. Now, people say to me, there's a big thrombus, how you can... Nope. I mean, you balloon it, you find the artery is open, you find the TIMI 3, there is no staining, there is no dissection, so no reason for you to put a stent. I mean, again, this will grow, and you might undersize, you might oversize. Why you want to enter an area and you have no idea? So this patient had a scoring balloon, multiple views, and you can see here and different views. We took look at the DCB, and we finished like this. So this is the artery which we finish with, young patient, in different views. I think it's not bad. I think no reason for us to think I want to heal this part of the artery with having a foreign body, if I can do it without that, which we did. And I think that patient now is only on single antiplatelets. Patient is doing fine. He came back to me actually with the vague symptoms. I did a TMT, and he's now on single antiplatelets. And actually at the beginning, only for 10 days, because he had some GI problem. So we stopped his both antiplatelets, put him on PPI. Then he said, look, I have vague symptoms of his statin. So again, I had to stop that one. And we put him on inclisiran. Now he's inclisiran. He's asking, can I stop inclisiran? Imagine, now he will be without medication. So, ladies and gentlemen, DCB represents the modern PCI philosophy. Precision preparation, which modification, biological healing, and minimalist in action. DCB is patient is power. I think we have to be patient. If you are not patient, you have to be patient for DCB. If not patient, then you have the stent to do. Restore the flow, respect the biology, and leave nothing behind. And thank you very much.
Thank you very much, sir.
To Abdullah for this excellent and insightful presentation. Unfortunately, I did miss Dr. Hishmat's presentation, but I'm sure it was an excellent one. You're the expert now in DCB, not only in the Middle East, but all over the world, and we are learning from you. I'm sure there are many questions coming, so please send your question to the chat box. Now, Abdullah, I do have many questions for you. Maybe a few of them you have heard them before, because I did attend many of your presentations. But let me just start. Of course, the concept of DCB, I think, is very attractive. No question about it. Having a procedure without leaving anything in the vessel, this is the ideal thing. And nobody will argue about that. But we just need to make sure that this is a safe approach for our patients. It is good to show the immediate result of a PCI using DCB. But what we need now is to see how that lesion would look like in 3 months, in 6 months, in 1 year, in 2 years. And in my view, and I'm very supportive to your approach, what we need, and you know that we live in the area of evidence-based now, and we did talk about it before. I think it's time to have our own clinical trial in our region. And we need to think about it and think what would be relevant, what would be different from what has been published so far, so that if we do the trial, then it will get published quite easily. So we need to think about it and, of course, start it as soon as possible. At PASCA, the Pan-African Society of Cardiology, we are very supportive of this initiative, and we do have some logistical platform that can facilitate that. We can ask some of our colleagues who are very much familiar with the clinical trials to support us. Now, let's go back to my question. With stenting, we feel really safe. And now, stenting without imaging is something that is not optimal. So do you think that approach of DCB, we can get rid of imaging so that we make it really simple? That's a procedure with DCB and no need of imaging, because we don't need to make sure that the stent is very well deployed. This is just a balloon. What do you think?
Habib, nice to see you, mashallah, and thank you very much for your excellent questions. I mean, no doubt, this is area we need more data. I agree with you because, people who are, scientific oriented like yourself, they want to see real data, not only in one center, multiple center. As I said to you, for me, there are evidence there for instant, for small vessel, for de novo, short and long term. As I've seen it, and the big one we've seen as well with the solution. The other one, which is area for me, is reflects. I think STEMI is similar to de novo with the more clotting, but easier to do. No doubt, I think we need to work together, all the centers in our region, to have share our data and follow them from different. But we need to agree on the principle of which Professor Hishmat, today is. I wanted really for him to be, because together we put this foundation of modification of the lesion. Once you do modify the lesion, there is no reason to say, look, why should I put a metal to deliver the antiproliferative medication? So if you can get the result acutely similar to the stent, then you deliver the medication. Now, what's the reason for you to not think you will not get the result in future? Is it because of a scaffold? The scaffold already happened by you ballooning everything. So only let the medication to work on long term. And I showed you a few cases today. I mean, most of my cases like this. In future, you get either same or positive remodeling, but it needs patient adherence to the medication. It's not only what you did with your DCB, it needs the secondary prevention. And that segment which you dealt with it with the DCB, that more response to the medication than when you cage it. I let also Dr. Hishmat to answer this.
So if I can take the part of the imaging, and Dr. Jamra is looking forward to get rid of imaging from coronary interventions. And I can see why, because of the extra cost it adds to the extra time and the learning curve. And so if we have a technology that doesn't require imaging, so maybe we get rid of imaging. And why not? If it doesn't add value, then there's no need for it. But we're still a little bit far from reaching that stage, because it's good to know what's the morphology of the atheroma that you're dealing with, because it might help you understand which tool to modify with. So if you find a predominantly, and we know also that calcification may not be very well seen on fluoroscopy. So you don't want to get surprised up front. So it helps you still to plan how to deal with the atheroma. That's number one. Number two, it helps you also estimate the proper size of the balloon that you're going to use, because we also know that angiography tends to underestimate the true vessel diameter. One of the advantages, I must acknowledge that one of the advantages of drug-eluting balloons is that they are much less dependent on imaging, unlike stents. But we still need to learn more about the vessel, if we have the luxury, of course.
Thank you very much, Dr. Hishmat. There's a question in the chat box. It says, what the difference between drug-eluting and drug-coated? I think it's the same.
Okay, then it's related to the platform, and an important point here, that there's no class effect of drug-coated balloons. And so what applies to one balloon will not necessarily apply to the other. And it's not just about the drug, because some people would argue that we have success with the Limas group of drugs with stents, whereas paclitaxel failed. So it's the Limas that's making the difference. But if we look into the data, we have paclitaxel coated balloons that failed, and we have paclitaxel coated balloons that worked well. And we have sirolimus balloons that failed, and we have sirolimus balloons that are booming. So it's not about the drug, it's about how we deliver the drug into the vessel wall. And so the newest platform, the solution, they have a unique mechanism of delivery where they have micro reservoirs. These reservoirs are released into the vessel wall. They are a bit fragile in the immediate phase, and then they keep eluting sirolimus for 3 months. That's what their pharmacokinetic and bench studies show. And they claim that the duration of elution is similar to that of the benchmark stent, which is designed stent. So that's why they would like to call themselves drug-eluting balloons. Whereas the other paclitaxel form, which I also respect a lot and has also very good results, they have the paclitaxel covered on the balloon with iobromide, something like iodine. And so it is released to the vessel wall immediately. And it doesn't stay as long as much as the other platform stays. So this is the first one is a drug eluting. The particles keep eluting the drug for several months. Where the drug coating, the balloon is coated with the drug and the excipient, and it just gets sticky, sticks to the vessel wall for a duration of weeks, definitely not months.
Do you think there's a difference in the effect in terms of preventing stenosis?
If we compare the two successful DCB platforms that we have, then we need a head-to-head comparison. And I'm not sure that we'll be seeing this in the near future, as we see with NOACs and other stents. Yeah, but they are both good in my opinion.
All right. Any other question? Khuzeima, you have any question?
Hello, good evening, everyone. Thank you, Professor Hishmat and Professor for such a enlightening presentation. So I think what I gathered from all the presentation is like I just listed down the 10 calls about DCB, basically DEB, what you talked about. So I'll just try to summarize what you talked about. One is that indications for DCB. I've just used twice, which was a donated balloon to me in Tanzania. I'm from Tanzania, so the practice is less. The cost is high. The cost here is $1,100. So we are still using the stents. And whenever we get an ISR, we still do stent in stent. However, we get tough times when we don't know the previous stent, what was the size and how it is placed. So we got those kind of issues. So one thing is that the DCB, DEB tells you that you leave nothing behind. So it's good for young patients, like Professor Shehab said, less medications, compliance, this thing. The most important thing which I picked up is the essential lesion preparations. Lesion preparation. And there's always a question that what sizing do you do when you use a pouring balloon versus the balloon you use for DCB? And I think it's literature says 1-to-1. So you need to size exactly as 1-to-1. And the timing of going with your balloon. Everyone says that it should be less than 2 minutes, because then the coated balloons, the coating starts getting disintegration. What about the electing balloons? Does it have a time to reach to this area where you are going to put your drug? From the time you insert into the catheter, it goes all the way to the lesion. If it's very effective in small vessels like distal vessels, distal LEDs, and side branches, and as we know. And plexiglaxil was brought in because it was highly lipophilic, but now, as you, Professor, you just said that sirolimus, they're almost doing as well as it supposed to do the plexiglaxil because of the lipophilicity and the high. But one thing which I have come across that you need to have, the more you scoring balloons, the more you make cracks into the vessel, the more drug gets, and the more intima healing happens faster. Again, very good for high bleeding patients where there is a high bleeding chances in older patients, so that less antiplatelets, less depth therapy in these patients. And I think like everything has been said very well. So thank you for such a enlightening presentation. And Professor Gamra, nice to see you once again, Abdullah. Thank you very much.
Thank you.
Nicely summarized. Thank you very much.
Okay, excellent. Just a few more questions coming. What percentage, in your experience, the question is for Dr. Hishmat and to Abdullah, what percentage do you convert from DCB to DAS nowadays?
Dr.
Hussein,
Abdullah.
you go. I mean, for me,
Okay.
nothing now.
If I will rephrase the question, after you modify the lesion, how many lesions will be treated by drug-coated balloons and how many will be treated by drug-eluting stents?
Yeah,
My ratio is 4-1. 4 DCBs and 1 drug-eluting stent.
good. Abdullah? 0%.
No. I mean, if happens, it's because of no. It's the reason, as I said to you, Wallah, if you follow the Dr. Prof. Hishmat way of preparing the lesion, do it and not to be in hurry. But if you're in hurry, you always end up with a stent. You ask yourself, why should I put a stent? Why should I put a metal? I mean, every time I ask myself, then I end up with a DCB. So that's what happened to me.
Sure. Comment on the carefree study, which was
I
published.
think he's referring to the Rick Cage-free trial.
I think cage-free, yeah.
Yeah, Rick Cage. It was published in the European Society of Cardiology in London, 2024.
Yeah.
It was seen as a setback for the drug-coated balloons. And what we learned from the Rick Cage study, the messages here and the lessons learned is number one, it is not a class effect. You will have balloons that fail and you will have balloons that succeed. And each balloon should be taken individually in terms of the results. That's why I'm very picky and very meticulous and very ubiquitous in the choice of my drug-coated balloons. I am approached by vendors every day coming, please use our drug-coated balloons. It has this advantage and that advantage. And I tell them, show me a randomized controlled study that proves your efficacy and safety. And if they don't give me a study, then sorry. So number one, every balloon is different. And the balloon that was tested was a Chinese balloon that was called Swide balloon. And we're not sure exactly how is the drug added to the excipient or how is it added to the balloon. So that's the first message. Not all the balloons are effective. Number two, even if you look to the balloon that failed in the Rick Cage free trial, in small vessels, it was equivalent to stents, which proves again the position of drug-eluting balloons. Even the worst platforms, they work very well with small vessels. Number three, even in the failing platforms like the Swide balloon in the Rick Cage free, the incidence of myocardial infarction was similar between drug-eluting balloons and drug-eluting stents. So that's another point in the favor of drug-coated balloons. And even if you look at the biggest fear of interventional cardiologists, which is abrupt vessel occlusion and early failure within the first few days, it was similar between drug-coated balloons and drug-eluting stents. So even if you take the, let's say, the worst platform, I don't want to say that, but let's say a failing platform, it is as good as stents in small vessels. It's as good as stents in preventing MI. And but the only difference was in repeat revascularization in the large vessels. So in my opinion, it gives strength to the position of good drug-eluting balloons.
So if I comment on that, Gamra, about even if you take the primary outcome of that and taking everything is fine, if you look at the reason for non-reaching the inferiority is the TVR. It's not the hard outcome. It's not because of MI, of MACE. It's because of restenosis. So that take us back that the modification is not being ideal. And I think if we go back and look at details of that, maybe that's the reason. And if the bigger the artery, you need a more better modification. So that's what I say to you. The modification is the therapy. You do the modification fine, that's it. You've done DCB. Otherwise, you should not put a DCB. But look at the solution study, which is multi-center, or the DCB, which we know, despite of that, despite of only using up to 28 percentage the specialized balloon, that means you're not getting ideal modification. Despite of that, you reach the non-inferiority. So imagine if we do every case modified balloon. So I think that's what we need. We need a really good modification to get the good result in future and reduce restenosis. So we need some work to do.
Sure. One question, Abdullah. The patients that you have been presenting today and, in the PAPSIC WhatsApp platform, most of them are quite young, in their 40s. Well, actually, the lesion is not fibrotic, is not calcified, where preparation would be quite easy compared to what we have now in our region, for example. The patients are in their 50s, 60s, calcified lesions, long lesions, fibrotic, where preparation most of the time takes time first, and ultimately we don't achieve a good result. Do you think age has to play a role in the likelihood of being eligible to DCB versus not?
If modification is not reach the criteria which you put, then okay, you will, I'm sorry I'm saying this, then you can hide your fault by metal. You can do that. But you should not give up. You should do your best, because even if you have calcification, you do everything, you put a stent, you get acutely a good result, but future still miserable. So whatever you do. So I think I leave my patient without a foreign body, but restenosis. At least I can deal with it in future. That's my answer.
Thank you. Dr. Hishmat, you have
Yes,
comment?
2 points. We need to, the concept of lifetime management is very clear in the TAVI. If you have a patient that is, let's say, in his 65, then you need to think of not only this valve, but also the next valve. And if we apply the same concept with coronary artery disease, I got a question on CABG, then you need not to think just of this intervention, but you need to think of the coming 2 or 3 interventions. And I would take the thread from Dr. Abdullah and what I see in my patients, that even when we have restenosis of drug-coated balloons, we will have restenosis, of course. It's not the end of history of intervention. The treatment of restenosis after drug-eluting balloons is much easier than the treatment of stent failure, because you just have one or two mechanisms. It's either neoatherosclerosis or neointima, and you can easily handle that. But with stent failure, you have a mix of 7 pathologies: neointima, neoatherosclerosis, underexpansion, malapposition, geographic miss, stent deformation, stent fracture, thrombotic tendency. That's 8 pathologies. And with diffuse in-stent restenosis, that's difficult to treat. And by using a drug-coated balloon, you preserve the future chances of stenting and of bypass. So that's why my first to-go device, probably until the age of 70, would be a drug-eluting balloon. Even when you grow older, then we move into another category, which is the high bleeding risk. And here's another advantage for drug-coated balloons. So across the ages, drug-coated balloons seem to be my favorite device.
Good. Thank you very much. I will ask Dr. Jaylan to ask his question at the end and make a comment. But there's another question before. Thinking of the future, is there a room for hybrid therapy, meaning DCB plus DAS in patients with multivessel disease? Will this phase out CABG in the near future, or at least reduce the rate of open heart surgery?
So you go ahead because you like stent.
Well, CABG is already phasing out. And this is dangerous because now it's hard to find good surgeons with large volumes. So CABG is already phasing out.
Sure.
And maybe in the future, we have drug-coated balloons as the first option, and then reabsorbable stents as the second option. When we have ugly dissections with flow limitation or persistent recoil, then maybe if the technology of bioabsorbable scaffolds evolve, if the technology evolves properly and we reach stable platforms, then maybe the future would be putting absorbable scaffold proximally and drug-coated balloons distally, but I'm still a little bit skeptical about bioabsorbable scaffolds. My experiences with it have not been satisfactory.
Yeah, I see that with the reabsorbable scaffolding, it's give you a kind of anxiety, get your anxiety at the acute stage because give you that scaffold, nice opening artery. But again, very expensive, more expensive, 3 times of the current stent. And it's not indicated for a lesion which we deal with nowadays. But I think it's nice, nice idea, but it should be very, very, very compared to the DCB. But otherwise, it's no rule. Can't hear you.
You're mute. You're on mute, Dr. Gamra.
Gamra. I'm mute.
Thank you so much for this excellent webinar. I did enjoy the part where I could share with you your presentation and the discussion, and I hope we keep going with this exchange of experiences and knowledge. And again, I remind you that we need to make a try about this. This will be a very powerful one coming from Africa and the Middle East and led by experts like you in the use of DCB. Mo, your question and final comment.
Actually, I think my question was reasonably well addressed, but I'll ask it just to be specific. Maybe I'll ask Abdullah, if you use rotational atherectomy, one of the reasons why we use rotational atherectomy is because in the post-stent era, we found that we were getting good outcomes, but in this plain old angioplasty era, the outcomes were quite poor. Do you think drug-coated balloons are an option, or would you always put a stent? Because I can see the advantages and disadvantages of either strategy. So maybe Prof. Hishmat, you can tell me.
Yeah, you ask a wrong person. You ask Hussein Hishmat to put a stent or not. So for me, after rota, you done the rota, in the past, because we had a plain balloon, the inflammation is there. How you subside that or reduce that inflammation is you have antipruritative with the DCB, which you deliver it. Well, of course, all depends on modification. TIMI 3, no recoil, no bad recoil, no bad dissection, no staining. Put your DCB. That will heal the injury for you. Yeah.
And you've got a case series where you've done that, I assume?
We have. We can share it, inshallah, me
Excellent.
and Dr. Hussien and from our region, yes.
Yeah, we look forward to seeing that during the Africa STEMI meeting. Maybe my only comment now is to thank everybody, the speakers, for wonderful presentations. I'm excited to have brought this particular presentation and topic to the Africa STEMI PASCI community and to the PAFSA community. These are excellent speakers who really teaching us specifics about how to do good coronary angioplasty with drug-coated balloons. They've posted there that next week's topic will be on bifurcation lesions. During STEMI Live on the 7th, I think, of May, we will actually have a dedicated 3-hour program on drug-coated balloons. And we're hoping that we will meet our speakers and people who are interested to come and have that dedicated learning. You'll be able to observe the differences between different types of drug-coated balloons and make decisions about the type of drug-coated balloon or drug-eluting balloon that you wish to use. I think my last thing is to invite our panelists and our speakers to make a final parting statement. I'll ask maybe Khuzeima, if you can just give us a quick parting statement.
Thank you, Mo. Yeah, thank you to all our speakers. It was just a great presentation, and especially that I think I don't know more how about Kenya, but I recently you had a protege balloon, which is like the folded balloon, which opens up and then gives out the medication. Recently, you had this in your last meeting in disasters. So I think this is upcoming for us. I mean, you guys have been using it, but I think as Professor said, that we need this kind of registry and studies in our region, and we can be part of all these things. So I think thank you everyone once again, and hope we see you all tomorrow and continue this great platform of School of Learning Intervention. And hope to see you all on 6th to 9th May at STEMI Africa Live in Nairobi. So thank you everyone, and see you next time.
Thank you, Khuzeima. Final statement from Hishmat.
I'm glad to be here. I wish I can make it to the Africa STEMI Live in May. Looking forward to that. Don't think too much about shall I put a drug-coated balloon or a drug-eluting stent. Focus on breaking the atheroma, on aspirating the thrombus, and on getting a good lumen. Once you do that, stent or a balloon, that's your call. But first modify the lesion and then decide.
Thank you. Very wise words. Abdullah.
So three things really. I mean, any lesion, just have three things in mind: modify, evaluate, decide. That's it.
Excellent. I see that they've posted two meetings, a semi-live meeting, but another very important meeting is the PASCAR meeting in Addis, which will be on the 31st of July to the 2nd of August. It's a PASCAR meeting partnered with the Ethiopian Society of Cardiac Professionals. And I've attended both the PASCAR and the ESCP meetings in the past, and I think the combination of the two will be quite exciting. A final comment from the president of PASCAR, Habib Gamra, before we close the meeting.
Thank you very much, Mo. I really enjoyed this webinar. Again, listening to experts on DCB. I'm really passionate about this topic. Abdullah, you know that. and I really learn every time I attend your presentation, the presentation of Dr. Hishmat. But again, I'm passionate about research, and I'm really waiting for something coming from our region, and I hope we can work all together to have an original idea of conducting as soon as possible before others come with other trials. We are ready to do that, and hopefully we can think of a great idea and start a trial as soon as possible. Thank you very much.